Stop.
Say like, hey, yeah. 50 people. With 250 hours. Yes, no, person would throw it out. I just need to. Exactly. Well, yeah, I'll take that.
Yeah, double check. You tell me the code is. Yep.
Or if we just want to stay.
Oh, I can do that. Yeah. All right, good morning, everybody. So welcome to Grand Rounds this morning. Mike Steinberg, I'm the Chief of General Internal Medicine. It's my pleasure to introduce our speaker this morning, Dr. Ethan Halm. Dr. Halm is Professor of Medicine and the inaugural Vice Chancellor of Population Health at Rutgers Biomedical Health Sciences. He's also a Deputy Chief Population Health Officer for RWJ Barnabas Health System. He's an experienced clinical and scientific leader, researcher, and mentor. He has 25 years of experience conducting federally funded research, over 250 peer-reviewed publications. His work is on health services outcome, comparative effectiveness, applied informatics, and population health. He's received as PI over $21 million in grant funding from NIH, AHRQ, and other foundations. His work focuses primarily on improving cancer screening, chronic disease management, factors that influence quality outcomes, and interventions to improve population health and health equity. He received his BA from Wesleyan University, his MD from Yale, and MPH from Harvard. He did his internal medicine residency at the University of California, San Francisco, and general internal medicine fellowship at Massachusetts General Hospital. He also has an MBA from the University of Tennessee. So I'm not sure how he found time for all of this. Most importantly, Ethan comes to us from the University of Texas Southwest in Dallas, where he had probably the most difficult and important job in an academic medical center, that being Division Chief of General Internal Medicine. So I look forward to ongoing learning all about that job from Ethan. We're very lucky to have him here and able to share both his research and his expertise in many different areas. So I'd like to introduce Ethan for our talk today.
All right, good morning, everyone. Thank you so much for coming out. I'm gonna go, this is gonna be a little bit of a funny grand rounds talk, but not like funny haha. I think it's gonna be a mix, and I hope it's gives you a couple of different things to think about. I'm gonna talk about understanding the concept of population health and types of population health activities. Appreciate the growing interest in population health from the patient clinician and societal perspective. I'm going to give two specific examples of population health successes, one in the outpatient setting, one in the inpatient setting, so hopefully something for everyone. And then I want to increase awareness of the current and planned pop health initiatives here at Rutgers. And at the end, I'm going to ask all of you for some of your help on how we can advance some of this work in ways that are relevant to you and your trainees. So the most common question I get is, what the heck is population health? And so it's a word that means a lot of different things to a lot of different people. And if you look on the bottom right, even the term pop health in PubMed really explodes over the last couple of years. So something's going on in its popularity, but it also means that it's a little confusing to understand. So let me take a crack at this. And the challenge is populations can be defined at very different levels. So it could be patients cared for in a clinic or a hospital or health system. Could be patients with certain groups or clinical conditions like those with diabetes or cancer, hypertension, asthma. It could be beneficiaries enrolled in a value-based care insurance contract. So our Medicare patients or our Medicaid patients or Horizon Blue Cross Blue Shield patients. It could be special groups like our employees or students, as well as residents of a geographic area. And this shows different levels and types of pop health populations relevant to pop health activities. And so if you look in the middle box, you could think, well, here we are at Robert Wood Johnson University Hospital. We could think about all comers to our ED or all comers to our clinics. But also we could think about, well, maybe it's patients with heart failure in our hospital. Maybe it's patients with diabetes in our clinic. It could also be employer groups. And so the RBHS Barnabas health system has 55,000 employees, and they are a self-insured group that are part of a value-based care contract. Rutgers, we have our trainees and our students are another big population. And then, of course, you have like FQHCs like Chancellor that have attributable populations. And then we can think about sort of cities or states like Newark or New Brunswick. And so population health approaches have multiple goals and tools, and I'll outline them here. So the aim is to really improve health of all members of a group, not just those seeking care. And that's an operative difference, I think, than sort of the hand-to-hand combat that most clinical medicine is still oriented against. The goal is to measure baseline quality of care outcomes, identify gaps, then intervene. Measurement is looking to leverage information in electronic health records as well as insurance claims to identify gaps, target interventions. There's a big predictive analytics component of this to identify who's getting suboptimal care or at risk for bad outcomes. And interventions can be at the level of the patient, a group, a clinic, a hospital or health system or community, depending on the target. We're going to use evidence-based interventions when available, innovate when necessary. And the types of interventions often fall into two buckets: an in-reach type of intervention and an outreach type of intervention. And let me explain this distinction. In-reach interventions are the things we're most familiar with of people coming into a clinic, and you see there's a best practice alert, or there's decision support, or reminder someone's not up to date on their screening, or the hospital might have a pop-up to sort of warn you about something. Or a case manager comes to focus on people who are at high risk. Those are people who are in front of you in the clinic and the hospital bed. Outreach implies really reaching out to people in between visits or for people who aren't seeking care to try to help get them the good stuff and improve their health. And I'll give you an example of one of that in a few minutes. The tools are really using both predictive analytics and behavioral and implementation science, health services research, and research within the pop health world often is using real world health data as a natural laboratory for observational and interventional studies compared to the randomized controlled trials, which may only enroll a few percent of an overall population with that condition. And the aim is to narrow the gap between patient care discovery and care redesign and better outcomes. This is the second most common question I get. Well, how is population health different than public health? And I don't know that I have an easy answer to that, but let me take a crack at it. It's also worth saying at the outset that population and public health share many similar goals, tools, and are complementary. This is not an either or thing. So if Perry Halkitis was standing up here as the dean of the School of Public Health, we wouldn't necessarily, have a battle. We've talked about this. So both disciplines aim to address patient, provider, system, and community factors influencing health. If I had to make the distinction, I think population health is much more health system engaged and targeted, and it really leverages the specific clinical information we know about defined groups, and as well as relationships with providers or insurers or employers to target interventions. And it's usually driven by the priorities of the health system, payers, or employers. Conversely, public health traditionally tends to be broader, more health policy oriented, maybe more community engaged. The CDC defines public health as it aims to protect and improve the health of communities through policy recommendations, health education outreach, and research for disease detection and injury prevention. And it's usually driven by the interests of publicly funded departments of health or schools of public health. The health system and health policy interest in population health is really because this is where the puck is going, or the puck has gone in a lot of parts of the country. So really moving from volume-based care and fee-for-service to value-driven care and accountable care. And the distinction here is when people talk about volume-based care, that's traditional fee-for-service. You get paid for everything you do. It's sort of widget-based reimbursement. The more you do, the more you get paid. The more you charge, the more you get paid. The more expensive setting, like an inpatient setting that you do a procedure, the more you get paid. And you lose money if you don't do unnecessary care. And the focus really isn't on coordination or high quality or longitudinal care of someone over time. Value-based care, which is on the journey to full accountable care, is the opposite of that. You're focused on managing populations, whether you see them in the clinic or charge an RVU for talking to them or putting something into them. You're really focused on trying to improve their health. You're trying to replace high-cost services with equally effective lower-cost services. Often this means doing things in an outpatient setting versus an inpatient setting. There may be shared savings if you're bending the cost curve or reducing unnecessary care. Collaboration and coordination is key. There are incentives for higher quality. And then there could be penalties for poor quality or poor outcomes. And the focus is more longitudinal on prevention and wellness, both primary as well as secondary prevention. And there are benefits of value-based care that accrue to patients, providers, and payers in society. And population health is needed to support the evolution of payment and care delivery reform that I think most physicians want, really moving from fee-for-service into more shared risk and capitation, and moving from volume-based sort of acute episodic care to overall management of populations longitudinally. The benefits of population health for the clinical missions of RBHS, RBJ University Hospital, and the health system is that academic health system partnerships provide so many opportunities to improve the health of the populations and the community we serve. And that's why we're in this business. I don't think we're necessarily just in this business to help the person right in front of us just for that, one encounter or that one hospitalization. And we as a hospital, we as a health system are accountable for the quality, safety, equity, patient-centeredness of the care we deliver to the public and private payers and various accreditation bodies. And so population health is the sweet spot, I think, where our joint missions closely overlap, and success will be accelerated by more research informing practice as well as practicing informing research. So applying evidence into practice and populations, and then using real world data and problems to stimulate research and innovative healthcare solutions. So this slide is a little busy, but let me take you through this. So I've tried to grapple with what people mean, what I mean, what insurance companies mean, what researchers mean by population health. I've come to bucket things into this new framework that I'm calling Pop Health 1.0, 2.0, and 3.0, because I think there are different goals and different degrees of difficulty in each of these kind of vertical columns. Where we are now is mostly Pop Health 1.0. This is like the flip phone of population health, of where we're starting. It focuses much more on the health plan and the payer perspective, because this is stuff that's on the test. So these are quality metrics for HEDIS. So those of you who are in the outpatient setting, it's the cancer screening, it's sort of patients with diabetes. Did they get A1C in the last 12 months? Is it over 9? Have they gotten urine microalbumin checked? You know, is the last blood pressure less than 140 over 90? Had an annual wellness visit, and their costs or annual utilization cost metrics in there. This is good stuff. This is where you want to start. This is what we have to deliver on for our value-based care contracts, but it's not really the be all and end all of what we think about taking care of people long-term, taking groups long-term well. Pop Health 2.0 is much more from the clinician and health system perspective. This is where we want to be moving. We want to really improve overall chronic disease. We want to reduce morbidity and mortality. Even in thinking about patients with diabetes, it's not just like, did you get an A1C in the last 12 months, but are we managing all of your risk factors, your glycemic control, your blood pressure, your lipids, your BMI, you're more physically active, are you eating better? For patients with hypertension, it's not just what's the last blood pressure, but what's sort of your area under the curve for your control, and what's your 10-year ASCVD risk? And then moving into Pop 3.0, this is, I think, what society cares for and what hopefully we can do over time. And I'll give you an example of this. We really want to improve the health and health equity of the patient populations and the communities that we serve. So lowering rates of MI or stroke or cancer or COVID or overdose, you know, are great Pop Health 3.0 goals. Are case fatality rates falling? Are we seeing a stage shift in the presentation of cancer or diabetes or kidney disease or HIV? Are we improving life expectancy or quality of life? Or in our patients at the end of life, are people spending fewer days in an institutional setting? And obviously addressing social determinants of health and underlying drivers of health inequity is really important, as well as societal costs. So we're mostly in the Pop Health 1.0 range. I'm hoping that you guys will help us not only make progress on Pop Health 1.0 goals, but start to make progress inroads into Pop Health 2.0 and eventually 3.0 goals. The other concept that I'm going to talk about is the learning health system. Advancing population health is a key part of progressing towards a learning health system. When I first heard the learning health system, I laughed, because every health system that I've worked in needs to work much more on its systemness, and then needs to learn. And so this seemed a little bit like pie in the sky, but let me take you through this, because I think it is a reality in some places, and it's an important aspirational goal. So learning health systems seek to continuously improve the care and outcomes of their patients and organizational structures and processes and cultures by using real-world EHR data and billing data and advanced predictive analytics, looking to improve and optimize EHRs and point-of-care decision support, use Lean Six Sigma quality improvement techniques to improve quality, efficiency, outcomes, patient experience, equity, do a lot of agile real-world experimentation with everyday work processes. In sort of the service industry, it's called A versus B testing. A lot of the tech companies do a lot of this without us knowing it. And pioneer institutions like Kaiser, like Geisinger, like Intermountain, you know, over decades have really built some of these processes and do a lot of this. And it's a much better world for their providers and their patients because of it. And in terms of an analogy, to build a learning health system, and these are bits and pieces that I'd like to see us build here, you need a robust sensory arm, you need a robust motor arm, and then you need a high functioning brain. And so in the sensory arm, it's using innovative use of information from EHRs, from claims data, social determinants of health, geospatial data, and mobile health data, The motor effector arm is going to be different kinds of interventions or better diagnostics or therapeutics or decision support, care management teams, population health outreach. And then the brain part is the kind of predictive analytics piece. And I'll give you an example of that. So that's where we're heading. I'm going to give you two big examples of types of pop health interventions to make this a little more concrete. So Mike mentioned that I spent the last 13 years in Dallas at the University of Texas Southwestern Medical School, working with the Parkland Health and Hospital System, which I'll describe in a second. But this is the characteristics of Dallas County, 2.4 million, basically a little bigger than a quarter of the size of the state of New Jersey. And the sociodemographics, even though there's a lot of wealth in the city, and you see it in the glitzy skyline, there's also a lot of poverty. So about a quarter of the patient population is uninsured, foreign-born, speaks Spanish in the home, has less than a high school education. And it's a majority minority city, county, with Hispanics being the largest group, then whites, and then African-American Blacks. And Parkland is not just a giant safety net hospital of 900 beds and a gazillions, hospital-based clinics, including primary care and specialty clinics. But Parkland is really a safety net Kaiser for the entire county of Dallas, because they also run 12 community-oriented primary care clinics for adults and kids. There are almost no FQHCs in the county. They're all run by the Parkland Health System. So there are all of these outpatient primary care clinics, as well as all the specialty clinics and all the acute care, is all linked on the same Epic electronic medical record, which makes it a lot easier to care for challenging patients because you know what's happened to them across different parts of the health system. And it's also a lot easier to get people into primary care, but there's still a dearth of slots available given the size of the population. It's the sole public provider for the uninsured in the county. So Texas has a very ungenerous state Medicaid policy. So Medicaid in Texas is for pregnant women and poor kids. So if you're a poor adult, you're out of luck. Thankfully, the taxpayers of Dallas County support the Parkland Health System with taxpayer dollars, and part of that provides Parkland financial assistance to people who are Dallas County residents and poor, which enables them to get both acute care as well as ambulatory care, as well as pharmacy benefits and things like that. And the work I'm presenting is the partnership that we did with the Parkland Health System and the UT Southwestern Medical School for an NCI-funded U grant for a center for colorectal cancer screening. My colleagues also had one for cervical cancer screening in vulnerable populations. And this is just to describe the National Cancer Screening Consortium that NCI funds called PROSPER. And the blue sites are the colorectal cancer sites. So when I say Parkland is the safety net Kaiser, we were in this consortium with Kaiser Northern California, Southern California, Kaiser Washington, which is the old group health of Puget Sound. And then the other sites, lung cancer sites, included places like Henry Ford and Penn. And then there were cervical cancer sites as well. So I don't need to tell a group of internists that colorectal cancer is common, costly, clinically serious, second leading cause of death. Only about 60% of insured adults in the US are up to date on colorectal cancer screening with much lower rates in underserved populations. Just think about that for a while. Like for how long, how many decades have we known how to screen for colorectal cancer? This is almost like if I told you that we only screen 60% of women for breast cancer, you'd think we were in an underdeveloped country. It's even lower in vulnerable populations. So at Parkland, when we first started this work, the rates were about 28% of eligible adults. And there's a lot of uncertainty about the most effective strategies in large health systems and safety net populations, especially comparing colonoscopy-based screening versus stool-based testing, visit-based screening versus pop health outreach. And the mantra in the field is the best test is the test that gets done. So I don't know if there are many gastroenterologists in the audience. I'm not going to fight with you about if colonoscopy is better than all the other modalities. If you offer someone a colonoscopy and they're not interested in that for screening, but they're willing to do a Cologuard or a FIT test, that's the best test for them. And in fact, so that's what we really did. And so most of you, all of you, I think know what the one sample sort of fit test looks like. You know what a colonoscopy scope looks like. You may have not had the pleasure of having one like I have, but it's a somewhat different patient experience. And I'm going to tell you about a pragmatic randomized controlled trial that we did to compare the effectiveness of two population health outreach interventions in that Parkland safety net population, of really comparing mailed fit kit outreach versus mailed colonoscopy invites compared to usual visit-based care in the Parkland safety net primary care population. So we had 3 arms, 6,000 patients overall. Usual care was the smallest arm. People just got whatever they got recommended by their PCP when they came in or not, and completed it or not. Arm 2 was the mailed fit kit intervention, where people got sent a 1 sample fit kit with both text and visual instructions for completing it in both English and Spanish. There's a returned prepaid envelope and simple, like 1-page explanation for the rationale for this. Arm 3 got a similar thing, but without really encouraging people to get a screening colonoscopy, explaining the importance of screening for colon cancer, as well as facilitation of scheduling if they are interested. And in the early parts of this trial, it was a sliding scale for colonoscopy in the health system. Most people paid nothing, but some people could have paid up to $25 in a copay. This is a pragmatic trial design because everyone was engaged in primary care as an enrollment criteria. So the mailed outreach arm patients could receive visual-based colorectal cancer screening if their doc recommended it. Patients could cross over, so they could have been in the fit outreach arm and said, I don't want that. My doc said I should get a colonoscopy, and they could have done that, and vice versa. And everyone got like a 1-pager low health literacy in English and Spanish about the importance of colorectal cancer screening, and a few reminder calls in the outreach arms if they did not respond. We focused on patients 50 to 64 who had at least 1 primary care visit in the prior 12 months before randomization, them not up to date with CRC screening, but average risk. And we only did the intervention in English and Spanish, although that really covered the vast majority of the population. This arm shows you that the randomization worked. Patients were 56 years old on average, 62% were women, half were Hispanic, a quarter Black. And people had on average just shy of 2 PCP visits a year. So these are not people who didn't have a doc, who didn't have a clinic or a usual place of care. They were engaged in primary care. They were seeing all of us trying to do the right thing. But yet a lot of the right thing wasn't happening for multiple understandable reasons. This is the results. And so the fit outreach arm doubled the rate of CRC screening compared to usual care on the right. And the fit and the colonoscopy outreach arm was intermediate, but statistically significant, better than usual care. This shows a treatment received analysis. And so the gray bars on the bottom show what people got to complete their CRC screening. So in the fit column on the left, most of the CRC tests that were completed were the actual fit we mailed to people. And then the white stuff above and above were people getting a fit through usual care, or colonoscopy through usual care. The middle column of the colonoscopy outreach arm shows that even though that intervention was much better than usual care alone, almost half of the CRC tests that got completed in the colonoscopy outreach arm were actually fit tests. And so there may have been a priming effect where the patient said, yeah, it's important for me to do this. I'm not so excited about screening colonoscopy, but when they came back in to see their PCP and they had a discussion about this, they're more likely to do sort of plan B to get screened. And then most usual care was done through fit testing. This graph shows a paper we did using all 4 healthcare system site data in our colon cancer screening consortium that showed that having a PCP visit nearly doubled the risk-adjusted odds of being screened, even in health systems that have very active population health outreach. So, and I'll show you an example of this in a second. Kaiser Northern California, for over almost 12 to 15 years has been very aggressive with a mailed fit kit program. And even in Kaiser, where people don't have to come in to get screened and they reach out to people, having a PCP visit still double the odds of being screened. So for those of you out there who are doing the hard work of being a PCP, your work is really important and complementary to what population health strategies are being offered. We made several other changes to the CRC screening process in the Parkland Health System. Parkland actually ended up moving to a fit first CRC strategy, in part based on the results of our trial, and in part from the reality that they have about the capacity to do 8,000 colonoscopies a year, and that includes all of the acute diagnostic colonoscopies they need to do. And so in a way, all the PCPs knew that there's sort of a run on the bank. Like if you referred someone for a colonoscopy, the likelihood they would get it in a timely fashion is very low, because the priorities are really for the diagnostic ones. And that fit first strategy is something the national VA has adopted. Kaiser Northern California has adopted that strategy. And we subsequently got a large grant from the state to take this to scale. And we were sending out 12 to 15,000 fit kits a year to Parkland primary care patients who are not up to date. We had an NP who managed all the positive tests from the outreach program. We changed some of the GI lab protocols to try to expedite the follow-up of positive tests, decrease the nuttiness and the pre-op clearance that was required, and simplify the prep. This infographic shows all the things we tried over a decade to try to improve CRC screening rates at the population level in the Parkland primary care population. On the computer is when we rolled out outpatient Epic, and we spent a lot of time building best practice alerts, reminders for cancer screening. Didn't change the needle, it didn't move the needle at all in terms of CRC screening rates. In 2014, the 3-prong icon, that's when we did our 3-arm trial. But it was only 6,000 people. That's not going to boil the ocean in terms of moving the population rate, and it didn't. In 2016, through a patient-centered medical home initiative, we were sending annual reminders for kind of preventive screening for people. That maybe got us a 1% tick up in the population rate of CRC screening. And it wasn't until we scale up the mail fit program and are sending out 12 to 15,000 a year that we see a spike up to 46% screening rate, which wasn't as high as what we got in the trial, but it was higher than when we started out. And then COVID comes along, and the mail fit kit program basically gets put on ice, and people are obviously focused on responding to the virus. This is a Pop Health 3.0 example. Kaiser Northern California recently published these data showing before they started their mail fit kit program, they're in the low 40% for both Black and white patients. They rolled out their program, and over the decades, they've doubled their rates from 40% to over 80% as a health system. Huge populations and big rises in both whites and Blacks. Even more impressively, you start doing much more screening, you get more early cancers, but then early cancers have come down in both Blacks and whites dramatically. Late stage cancers come down with this approach. Any cancer, any CRC cancer comes down significantly. Huge drops. This orange line are African Americans who have higher rates of colorectal cancer incidence and mortality. Huge drop. And then even most impressively, over this 15-year period, deaths from CRC have come down in both groups. And so this is probably the strongest evidence that I can find of this kind of pop health outreach strategy, which isn't very complicated or high tech, can make a huge difference in patient outcomes, as well as costs of caring for common cancer. So let me segue to an inpatient example. So those of you who do inpatient work, I'm going to talk about an ER-based clinical prediction model to improve population health and really focusing on predicting and reducing the risk of readmissions. I don't need to explain to this group that unplanned hospital admissions are frequent, they're costly, many of them are potentially avoidable, and they're unpleasant experiences for everyone involved. We know that Medicare penalizes our hospital, like many others, for if we have a higher than 30-day readmission rate. This hospital loses a lot of money because our readmission rates are higher than predicted. That Barnabas health system loses a lot of money each year, and several $1 million a year, because our readmission rates are higher than expected. And this CMS, the Medicare folks focus on patients with MI, heart failure, pneumonia, COPD, and then the surgical realm, CABG and joint replacement. But it's not really feasible to do maximal transition of care interventions on everyone and 24/7. And so there's only so much you can do. So it seemed like a great idea for some risk stratification and targeting. So I want to present to you a work we did on predicting and reducing the risk of readmission in heart failure. So heart failure is the most common reason that a Medicare patient is hospitalized. Very costly. Many of these are potentially preventable. EMR-based readmission models are promising because they can tap many domains of risk, because we have granular data in EPIC on disease severity, comorbidities, mental health, substance abuse, as well as physiologic reserve, social determinants of health, and then you can get prior utilization patterns. And the goal is to produce actionable intelligence that's usable in real time. The Medicare risk models for heart failure tell you, based on bills, claims that's submitted, last year, this patient was high risk of readmission. That's not helpful to the clinical team. That may be helpful for profiling hospitals or maybe penalizing or rewarding them, but that doesn't help us do a better job with our patients. So we took a something old, something new approach. We started out with something old, which was a heart failure mortality model developed by Tabak that essentially is like an Apache score for heart failure, uses age, lab values, and vital sign data to predict the risk of 30-day death in an inpatient with heart failure, derived in over 900,000 patients, 195 hospitals. It had a very high C statistic from a predictive accuracy perspective. The something new was to really try to get at more social determinants of health and behaviors that we know also drive the risk of readmission. So not only looking at age, sex, race, ethnicity, insurance status, but housing instability. Is someone homeless? We looked at the number of address changes in EPIC as a measure of housing instability. For social support, we looked at whether people were single or married. We also looked at whether the number of emergency contacts in the EMR, with the hypothesis that if you had no emergency contacts, you were really alone and isolated. Different measures of mental health, both ICD-9 codes for substance abuse, as well as if people had drug testing done, regardless of the result. We mapped people into high-risk census tracts. We looked at certain adherence behaviors, like their medicine refill rate in the Parkland pharmacy and their outpatient show rate, as well as prior admissions and ED visits. And we used data both from the Parkland EMR as well as a regional health information exchange and some community databases. We did the prediction work on almost 1,400 patients. This is a young, old group. So the average age of the heart failure inpatients were 56 years old. 62% were Black, 19% Hispanic. Half had Parkland County financial assistance. 69% lived in the lowest quintile census tract in terms of socioeconomic status. And most people had prior admissions and ED visits. And their 30-day readmission rate at the start of this work was about 25%. And a third of the admissions were to a different hospital other than the safety net hospital, which was a little bit of a surprise to us because none of the hospitals in Dallas want to take care of uninsured patients because they can't get them emergency Medicaid to pay for them. This table shows by kind of domain, the different factors in the final heart failure model. So we have the mortality score, just like the Apache score of labs and vital signs. This is the interesting stuff. In red are the social determinants of health factors that increase the risk of readmission, being single, having depression, anxiety, history of cocaine use, number of address changes, being in a high-risk census tract, even though these are all low-income patients to start out with because they're in the safety net system. History of missed clinic visit. Using the Parkland pharmacy for refills at a high rate was productive. And then obviously the number of readmissions was prior readmissions is a factor. This graph shows that the black and white bars show derivation of validation samples. So The model worked pretty well because these buildings are about the same size across all the different quintiles. But most importantly, the model really differentiated people at low risk versus high risk. So in the low risk, people had about an 8 to 12% 30-day readmission risk. In the high risk quintile, people had a 50-50 chance of being readmitted within 30 days. And so that's where we targeted the intervention to reduce readmissions. So we look to identify heart failure patients in the first 24 hours of admission using diagnosis codes as well as NLP within the admit note. Identify the highest risk patients for a mix of both inpatient and outpatient transition of care interventions. And the heart failure nurse saw patients who are highest risk during the hospitalization, sought to optimize their care. A pharmacist did medicine teaching on discharge. People got into a heart failure clinic appointment within 7 days of discharge, which really took a lot of work to get the cardiologist to free up those open access slots, but they were hugely impactful partners in this. And then in the outpatient side, people obviously followed up with the heart failure clinic within 7 days. There was a pharmacist who called them to check that they got their meds, answer any questions, and then there was a nurse visit for those at the highest risk. And this run rate graph shows that just by targeting the highest quintile risk people during Monday through Friday work hours, we intervened on 22% of the overall heart failure population, but got a 27% absolute reduction. I'm sorry, 20% relative reduction in readmissions. And the hospital calculated that we saved them $1 million in the first year. So much so that when the grant that funded this ran out, the hospital said, no, we're continuing this. We don't care if the grant money is going away. That had never happened to me before. And this table shows a more rigorous analysis with risk adjustment, showing that the absolute rate of readmissions in the heart failure patients in the overall population dropped from 26% to 21%, 27% relative reduction. Even a bigger drop among the subset of patients with Medicare who are older, almost a 10% absolute drop in readmission rates. And then the concurrent controls were people with AMI and pneumonia, with the hospital was still worrying about because they got penalized for those and they were doing some generic transition of care interventions, but there was no statistical drop in the readmission rate in those tracer conditions. And then finally, we did a dose response analysis that showed that if people got none of the outpatient follow-up components, they didn't have a lower 30-day readmission rate. But if they got 1 or 2 or 3 or more, they had big drops, 27% relative drop, 65% relative drop. So even though the inpatient, the stuff intervention started inpatient, it was really stuff after hospitalization that made the biggest difference. Let me transition now to some things that we're going to try to start to do here, and I need your help with this. So we've started a Rutgers Population Health Consortium to be a cross-bridging entity across Rutgers and RBHS and UH Newark and our other partner institutions to bring together scientists, clinicians, educators, community engagement experts to advance population health. We have members from all of the Rutgers Chancellor-led units and the main health systems. We're looking to foster collaboration on research, education, other topics. This is work that Mary O'Dowd and I co-share. And so those of you who have interesting work in this space, let us know. We're always looking to feature the work of our faculty and looking for collaboration, dissemination, implementation opportunities. In the research realm, we're going to be looking to advance the breadth, depth, and impact of population health research here in collaboration with all the deans, directors, and chairs to foster more collaborations, to increase grants and reputation in this area, to promote the use of health system, state, and national data for observational interventional studies. We need more horses here at Rutgers and RJMS to do this work. So we're going to be looking to recruit faculty in this area. Hoping to start a population health fellowship that would be like a T32 that people could do on the tail end of their subspecialty fellowship, or general internists, could do this to learn these skills. And I'm hoping that people will contact me and share their ideas for population health projects, for pilots. Let me help you and others with recruiting people. In the education realm, the goal is to integrate principles and practice of population health and health system science in all of our RBHS schools, both for early learners, UME med students, as well as advanced learners, our residents, develop both formal didactics, but probably even more importantly, some experiential practice-based opportunities to delve into improving pop health and health equity in their own patients. So I need your help and ideas for what do our trainees really need to know to thrive in the New World Order. So if you're working with med students, what are the med students learning here? What do they need to learn? If you're working with residents, what do the residents need to learn in their continuity clinic to take better care of their patients, to be able to get a job and be able to be the leaders of the future? And so please share those ideas. And I was talking with Renita just before the talk about thinking of getting a group together to think about what's going on with our residents, and especially in their ambulatory blocks that we can maybe work on. In the clinical realm, we're looking to develop, implement, evaluate, and disseminate impactful population health initiatives throughout the health system. My big audacious goal is to have a population health and disparities dashboard at multiple levels, at both the hospital level, the health system level, the practice level. We need your help collaborating on this work. I'm going to be getting in touch with some of the general medicine primary care folks to help with some Pop Health 1.0 work and some pilots on improving colorectal cancer screening to start out with. But I want you to get in touch with me, share your ideas for other Pop Health improvement or learning health system pilots that we could use to make progress towards sort of Pop Health 2.0 goals, whether this is in the specialty realm, the primary care realm, inpatient, outpatient. We need your ideas and energy. Community engagement is really, there are a lot of incredible community engagement experts here, so we'll be partnering with them on this. And then we're going to be developing a Rutgers Health Service Corps built off the success of the VAX Corps that involves so many health profession students and college students, but to give them a way to get engaged in population health besides just responding to the pandemic. So this is going to be an interprofessional group of students of all degree levels, college students, health profession students, faculty, and community members working together to improve pop health through education and service. We'll provide interprofessional training and service opportunities to support their career development, hopefully get more of them interested in careers in health, population health, public health service, hopefully help increase the racial, ethnic, and socioeconomic diversity of people moving into our health professions programs. There'll be both online educational modules as well as service learning. And this is where the fun happens of the students getting involved in screening. And we have a pilot going on at University Hospital Newark, where they're working on breast cancer screening among low-income women going to the emergency room who don't have medical homes. Let me just finish up by mentioning a few other early population health initiatives, which I hope some of you will hear more about and partake in. So I'm co-leading with Frank Nelson an equity and population health working group for the hospital here to try to measure and then address health disparities within the walls of the hospital. The first step is to try to improve the collection and coding of race, ethnicity, and language preference in EPIC. And we're working with the patient registration folks to try to get that more faithful, because if you want to, my goal is that for every report we have on mortality, safety, patient experience, length of stay, readmissions, that we not only look at the group overall, but that we stratify by race and ethnicity to really understand which groups are we doing less well with, that we really need to double down and understand why. We've got some pilots with Jeff Carson's help looking at Black-white disparities in the management of pregnancy-related anemia. We've got a pilot, some pilot work that's going to start looking at heart failure disparities. We have a new learning health system implementation committee that Ray Panettiere has really encouraged and support us to start to promote healthcare innovation projects, both in the hospital here and the overall health system. We're working with the health system Pop Health team to improve cancer screening, diabetes, and primary care access. We have a pilot going within the RBJ Barnabas Health System Employee Health Plan to try to work with our employees who have diabetes to get better control, as well as to improve cancer screening rates in healthcare workers. We have some early collaborations between Rutgers researchers and health system leaders in the area of cancer screening, cardiovascular care, substance abuse, and mental health. And then for those of you who do research or are working with residents or fellows who do research, there are a growing number of databases that will be helpful. So we have a new clinical data warehouse where all of the EPIC data is getting poured into for both research and QI projects. We now have 7.5 million records, even just from the first few months of getting the feed on this. As more of the inpatient sites come online, it will be even more robust. And then the Institute for Health, Center for Health State Policy has multiple state databases that people can use for research. Let me stop there, and I'm happy to take your questions and comments and ideas. And I've listed my email here, and I'm really hoping people will reach out to me with ideas, both people in the room, people on the Zoom, for areas where we can really start to make some inroads in this area. So thank you very much. Should I go to the chat, Dave?
But before I forget, so for those of you, I forgot to announce the code for grand round today is 14331. I was supposed to announce that before, so sorry about that. Questions? I don't know if I'm going to start with questions in the audience here or.
Yeah, please go ahead.
Thanks so much for your talk. Really let you know that we've been working. So it's incredible. People just apparently like $1 million with like if you do something cost is so high. I used it, right? So from that we learned a lot. And population is quite huge in terms of fascinating that this kind of work that's happening across our one-on-one area is important, but looking at the community and making sure.
No, that's great. That's really, I mean, congratulations on that success. Is your last name Dr. Hussein?
Yeah.
So Dr. Hussein, for people on the Zoom, was talking about some amazing work that they've done in the ICU here to really measure and then address social determinants of health among critically ill patients and how that has made improvements. So please do me a favor. Would you mind sending me an email and so that I and send me a copy of that article so I'm get more up to date about that. That's really terrific. Obviously, there's now the social determinants of health wheel with an EPIC. So one of the things we need to do is not only identify these things and then figure out what do you do when parts of the wheel light up red, and plug people in, especially the community-based resources. And so
I have to really credit Carol. Carol's really part of my social work. Help us make sure that we connect have all the mechanisms.
Yeah, no, that's terrific. So it's a my health kiosk is yeah. So send me more information about that. That's really terrific. It's also a good example of we need to worry across the whole spectrum of care about how to take better care of people. And also to not be too cynical about the ability for both people to change or us to be able to engage, challenging and sick people. Other questions or comments?
Yeah, you can't look at it, it must be very. I think part of this is big, but it's changed.
Yeah, it's right. So the question in the room was really about sort of care fragmentation, that you have patients who may be going to different hospitals in a region like here. And I think it's a great, I mean, the answer is we have a ton of fragmentation. The interoperability